Hi, welcome back. I'm Dr. Bhargava, and in this short video, I will share some interesting nuclear medicine cases with you. Our first patient was suspected of having osteoporosis and underwent a DEXA scan. On this DEXA scan, we have an image of the lumbar spine with region of interest marked, bone mineral density measured, and a T-score annotated. And below that, we have an image of the right hip with the region of interest and the T-score. And we find that if we report the neck T-score, it is minus 3.4 and it is less than minus 2.5. So this patient has osteoporosis by the WHO criteria. Looking at this lumbar spine image carefully, we find that the L3 vertebral body is abnormal. It is more sclerotic than the vertebra above it and the vertebra below it. And also, if we look at the height of this vertebral body, it is less than L2 and L4. So that makes it concerning for a insufficiency fracture. And so here is the lumbar spine plain film on this patient in the lateral projection showing that there is an anterior compression deformity involving L3 vertebral body. So when there are compression deformities of the vertebral bodies, we want to be able to recognize them on the plain film from the DEXA scan, and there is decrease in height of the vertebral bodies. They become more sclerotic as we see here, and because of that, their bone mineral density is higher than other vertebral bodies. And that's exactly what we see here. So then this patient now has osteoporosis with an insufficiency fracture, and per WHO criteria now they have severe or established osteoporosis, which stands for more than 2.5 standard deviation below the young adult mean with a fracture. So analysis of the lumbar spine image and also of the image of the femur is very important because there might be some findings in those images that may have the potential to change patient management. This is our next patient. They were recently diagnosed with lung cancer and they underwent a whole body FDG PET-CT study for staging. So let's start by looking at the rotating image. And so it is very clear from this rotating image that this patient has extensive disease. There are innumerable scattered foci of intense uptake involving the ribs, the spine, and the pelvis. And so they have multifocal bone mets that are FDG avid. Here is a representative axial image from the CT part of the PET-CT showing that they have this hypermetabolic mass in the left lung, and this is in the AP window. There are adjacent hypermetabolic lymph nodes. And here is a coronal fused PET-CT image showing these multiple foci of intense uptake involving their axial skeleton. The interesting finding about this patient is that these lesions in the bones were completely negative on their CT. So on this slide, we have a contrast enhanced CT image, CT chest image showing this hypermetabolic mass in the left lung with adjacent lymph nodes. We saw the hypermetabolism on the previous slide, and we are looking at a sagittal image from the CT chest in the lung windows and also a sagittal image from the CT of the abdomen and pelvis in the bone windows showing that there are no focal lesions. And so this happens once in a while where we see focal hypermetabolism in metastatic disease on a FDG PET-CT study or a whole body bone scan, and the CT scans are completely negative. This is a good review article on bone metastases in non-small cell lung cancer patients. Here's our next patient. This patient has previously been treated for prostate cancer and presents with rising PSA, and we performed a PSMA PET-CT. Let's start by looking at the rotating image. So here also the rotating image from the PSMA PET-CT shows that they have extensive disease. They have a hypermetabolic retroperitoneal lymph nodes extending from the upper to the lower abdomen. They have a focus in the chest, and they also have this hypermetabolic lymph node in the left supraclavicular region. And so that lymph node, which is also called the Virchow's node, is seen here. Here's the lymph node, and it shows focal uptake. And some of the other findings are also shown here. Retroperitoneal lymph nodes that are taking up PSMA and aortocaval lymph nodes that are taking up PSMA. So they have extensive metastatic disease plus a Virchow's node, which is in the left supraclavicular region. There is no focal uptake in the prostate, and previously they were treated with radiation therapy, and there is no evidence of local recurrence. This is an article, and this describes the visualization of Virchow's node on PSMA PET-CT. And the authors say metastases to Virchow's node has also been reported in men with prostate cancer. However, this has generally been observed at a low frequency of only 0.5%. Thank you for watching.